Welcome to the Paedshub Pod, an educational podcast created by paediatric trainees in the Southwest.
Featuring reviews of journal articles and interviews with authors and specialists.
Please note, these are our own opinions and do not substitute professional medical advice.
Thanks for listening.
Hello and welcome to the Paedshub Pod annual roundup. We're fortunate to have all of our hosts together on a Teams call, which is amazing. In this episode, we're going to signpost you to 12 articles published this year that we feel are worth a read. All of the references and links to the articles are in the show notes. To reintroduce ourselves, we are all paediatric trainees in the Southwest. My name is Felicity and I'm a new community grid trainee. I'm passionate about caring for vulnerable children and I'm particularly interested in paediatric palliative care.
Hi, I'm Lorna. I'm an ST3 paediatrics trainee with a particular interest in neurology. I continue to enjoy the wide breadth of presentations we're exposed to in paediatrics and the problem solving that it involves.
Hello, I am Leila. I am also an ST3 paediatrics trainee and an OHR academic clinical fellow, and my clinical and research interests are in childhood cancer.
Hi, I'm Paulina. I'm an ST8 PEDS trainee, and my interest in PEDS is more in the areas of global health and health inequality, but I'm also developing a subspecialty in renal medicine.
So, to our first article.
Number 1.
So the first article is taken from Archives Disease in Childhood, and it's titled Barriers to Initiating and Implementing Palliative and End-of-Life Care for Children with Life-Limiting Conditions, a mixed method study in a UK children's hospital. So what the authors of this paper aim to do was to explore the challenges that are experienced by paediatricians caring for children with life-limiting conditions and the barriers to providing end-of-life care. They used semi-structured interviews and an online questionnaire. This was back in 2020-2021, so the study was impacted by COVID. The main themes identified related to concerns around training in paediatric palliative care, concerns around leadership when a child has multiple specialities involved, issues with preparing advanced care plans, communication challenges, particularly when there's a lack of consensus, and concerns were raised about recent high-profile cases. In addition to that, they also identified that there's challenges in sometimes identifying children who are life-limiting because actually there can often be a lot of uncertainty. So some of my main learning from it was that actually it's really important for us to advocate for ourselves as trainees to have training in paediatric palliative care and the importance of building good links with the paediatric palliative care teams, and also the timings of some of the end-of-life care discussions. So when consultants were asked to consider their most recent care they provided for children at the end of life and those care discussions, 5 out of 17 started when the patient was in intensive care, and 8 out of 17 the conversation started with an acute admission. So actually I suppose that's when the opportunity is happening, and it highlights that sometimes it can be really hard to have those conversations outside of that acute setting.
So that's really interesting, Flick, and I'm really pleased that you bring it up because I think there's so many conversations to be had around how we as trainees are involved in not only delivering palliative care but sort of broadening our understanding and how we can bring that up with patients, earlier on in their journeys. And one thing that I think we're really fortunate to have in the region is the MAPLE course, and it's been set up by a group within Bristol and I believe primarily within the PICU setting, but actually it covers sort of those discussions towards end of life, and it's very much focused around communication. And yeah, I think it's got a wide national reach now, and people are coming from across the country to attend. And I was fortunate to attend about a year ago, and it really enlightened me to just kind of being a bit more cognizant to the conversations that we're having, and actually thinking how you can get feedback on those to continue that reflective and improvement cycle.
Yeah, I've heard really good things about the MAPLE course too. The other thing that people have fed back positively about is the professionals days, where people can go and visit local children's hospices. I'm not sure if you guys have visited.
I haven't myself, but I know of a few people who have visited Cheltenham Farm. And I think it just probably contextualises a lot of those conversations that you have with families. So again, yeah, lots of opportunities, I think, to explore the whole pathway.
I actually went to visit Littlebridge House and the team showed me around there, which was a surprisingly lovely experience. Within the space, there was a lot of joy. There were a lot of fun rooms, things for the kids to do, but for the siblings as well as for the child who was palliative. So it's a really supportive environment with amazing professionals. And I would recommend anyone go and have a little look just to understand what it's like so that you're better able to have those conversations with parents about, next steps going forward.
Number 2.
I'm going to talk about papers with more of a perinatal and neonatal focus. And the first one is pharmacokinetic and pharmacodynamic data from the NEOLEV1 and NEOLEV2 studies. These studies are about evaluating use of levetiracetam in neonates because it's not licensed for use in neonates. And they wanted to test this further because there'd been a previous randomized control trial where the efficacy of levetiracetam in eliminating seizures was really poor in comparison to phenobarbital. So they were intending to use higher doses to see if it was more effective. So it summarizes the results from these two studies, NEOLEV1 and NEOLEV2 in the US. And they looked at the clearance, the volume of distribution, and the seizure burden associated with giving levetiracetam to neonates that were more than 36 weeks gestation and less than 2 weeks old. I'm mainly going to talk about NEOLEV2 because in NEOLEV1, the doses were effectively, again, too low to have a significant effect. So in NEOLEV2, they used 40 milligrams per kg at seizure onset, and then a further 20 milligrams per kg of levetiracetam if the seizures continued, and then this was followed by maintenance dosing. So the positive outcomes for the study is that the pharmacokinetics were really predictable at high doses, and as we know, it has a better side effect profile than phenobarbital. The unfortunate outcome of NEOLEV2 was that standard dose levetiracetam had a poor effect in that 28% of patients remained seizure-free for 24 hours, as compared to 80% of patients on phenobarbital. However, 25% of the patients did have their seizure burden reduced, and this was proven by the EEG monitoring. And then an additional 7.5% efficacy of levetiracetam was achieved with the addition of a second load. So the results were all gradually getting better. And these data basically allow further study. And they're going to do another trial, NEOLEV3, to escalate the dose, which will be working towards a daily dose of 200 milligrams per kg per day. And I just think it's interesting because we've been using phenobarbital for a very long time. And actually, in recent years, levetiracetam's gained popularity because it's a very safe drug, and we've now changed the APLS protocol to include this. After the first 2 doses of benzos, levetiracetam is now the next option when we're treating seizures. So it's probably a great option for using in neonates, and it may just be that it seems like neonates just need much higher doses compared to adults and children.
I think it's just so interesting what we've done for so long without evidence and good quality data. Particularly in neonates, it's amazing to now have these studies coming through.
Yeah, definitely. And, in the patients where it did work, the response was rapid. It was like less than 30 minutes that their seizure would improve. But it just seems as though there's obviously some variability and the dose just isn't high enough to actually capture all these neonates.
I was going to pick up on a similar point, actually. And I think it just highlights the importance of ensuring that, we have these trials in different populations. And I think that the kind of sort of really prominent point of conversation is actually thinking about patients from underserved populations and their involvement in trials, because when we're looking at, the idea that some neonates might respond differently to different doses of levetiracetam and trying to understand the pharmacokinetics there and other sort of drivers for that variation, it would be really interesting to delve into the reasons behind there. And I think when we're talking about healthcare and health inequalities, that should be a part of this conversation as well. I have to say, one thing that also was quite interesting, I suppose, is the idea that they've also used EEG as sort of a marker of seizure activity, which obviously we do normally in clinical practice. But actually the use of, I guess, indirectly measured patient variables as an outcome for a trial is also really interesting as well. And you can see how that is quite easy to communicate, and perhaps even more so than like the clinically observed seizures.
Definitely. I think that, I guess, the subclinical seizures is something that we probably don't know enough about anyway. And EEG interpretation is really complex and something that we perhaps don't get quite enough exposure to.
So one resource that I go back to time and time again are the Toby manuals. So I think they were designed for cooling, but they've got some really good descriptions of CFM and pictures so that you could, just regularly refresh your mind. But yeah, the subtleties of seizures on CFM, especially if a child has some movement, some artifact, it can be quite difficult to interpret the subclinical ones. And you've also got to remember that sometimes you're going to pick up the cardiac beat on the CFM, which can sometimes look like potential seizures, but you just have to be aware that can be artifact.
Number 3.
So this article is from the Archives of Disease in Childhood, and its title is Family, Poverty, Neighbourhood, Greenspace and Perinatal Outcomes. So this research aimed to determine if green spaces in urban neighbourhoods can reduce the impact of low income on perinatal outcomes such as birth weight, gestational age and early developmental delays. So this uses data from the Millennium Cohort Study, which is a UK-based population of around 19,000 children born in 2000 to 2001. And this particular study looks at green space exposure on outcomes such as birth weight. And this was particularly interesting because the sort of main finding that it reports is how low-income families living near more green space experience an average increase in gestational age of about 3 days after you account for all the confounding variables. But there was no impact on things such as birth weight or communication or motor delays at 9 months. But whilst it's, arguably, the sort of clinical relevance of 3 days is perhaps, up for debate, I think there's something really interesting here in that it combines this idea of the environment in which we're living in, the many other factors that link into health and well-being, as actually having, on a population level, an effect on a perinatal outcome.
Yeah, I'd just be interested to know more about what the actual setup was and how much time these families were spending in these environments near their home.
Absolutely. And I think that is the key question. And I think the thoughts are that you would then need to look at that in more detail. So the idea that with this being such a large cohort, that you're able to pick up on these initial patterns, and just that they had a decile rating in terms of closeness to a green space in urban areas. And I think it's like the idea that you can show that association initially, and what the particular driving factors, whether it means you're exercising more, whether it means that your sort of exposure to pollution is different. I'm not quite sure. And I think there are some theories around that. And again, things that would need to be measured perhaps in a slightly different way, just because, again, when you're looking at these population level data, the way the information is calculated is kind of based on their postcode, I think, and like mapping out things. So I guess it would just be a different question of like physical activity and other things that are related to that. But yeah, I think that the conclusion that was drawn by the team was that, you could use this as a driver for integrating nature into urban planning. And I think it's quite cool, again, to think of like that intersect between healthcare and, this data that we collect, and, it's very public health related, but then feeding that back into the physical environment in which people live and, using that to drive policy and all these sort of things. I think it's just a really cool way to show that process.
I like that you mentioned, policy making and public health and the impact that can have, because that's so important. And I think increasingly we just need more evidence, and they're not, to actually make significant changes and have an impact on politicians. They want the numbers, they want the statistics. And so it's really useful.
Absolutely. And again, I think it's really nice, for us when we are thinking about patients who come through and are part of perhaps bigger trials. And I think this is probably going to be true for a lot of the papers that we bring to the session. But when patients are on trials, sometimes you don't always hear the outcomes of those. And particularly like when you think about the impact might be even beyond like how we change our local guidelines or national guidelines, but actually like the policy and the like huge remit for like changing scope of practice and life.
Number 4.
I also picked an article which had a bit of a public health theme, and that was an article published in Archives titled "Near Fatal and Fatal Asthma and Air Pollution. Are we missing an opportunity to ask key questions?" And so what they discuss is the fact that there's only been one reported case of a child dying of an asthma attack that was associated with air pollution, and that was a case in the UK. There's evidence emerging which absolutely seems to support the link between air pollution and asthma attacks in children. But the authors in this paper discuss why there's a lack of evidence on fatal and near fatal asthma attacks that are linked to pollution. And what they essentially say is that thankfully fatal asthma attacks in children are still relatively uncommon, that measuring and interpreting personal exposure to air pollution is really challenging and difficult to interpret in this context. And thirdly, that the studies currently coming out aren't being designed to answer the question and to look at this well. So they feel that the systems for data collection need to be improved. What I thought was really interesting was that they have this quote that current harmful levels of air pollution are often not visible to the naked eye, and yet are silently contributing to an estimated 28,000 to 36,000 deaths per year in the UK, and that the UK air pollution levels are currently higher than that recommended by the WHO. The British Paediatric Surveillance Unit team are doing a study on near fatal asthma, so it'll be really interesting to see their results. I think they've finished collecting the data now, so it'll be interesting to see when those results come out. The other thing the authors suggested to try and help is that when we're coding diagnoses, that we should try and be as accurate as possible. So rather than saying a child coming with asthma, saying that it's near fatal or life-threatening asthma, so that then when they're pulling their data and they're looking at these studies, that it's easier to find these patients. They've also come up with a suggested list of questions that we can start to incorporate into our history taking that I hadn't really considered before. So things like, is your home positioned beside a source of traffic? How do they ventilate their homes during peak times? Are the windows open or closed when there's rush hour traffic? Do you need your inhaler when you're walking beside a busy road? They're quite interesting questions that I hadn't really considered before.
And I suppose that links into some of the existing things that I think are perhaps more ingrained in practice, where you might be more inclined to ask if there's any like mold in the home and other components. So I think I wonder, it would be really interesting to look back and think, was the literature, 5-10 years ago around association between like fungal asthma and, I know there's more discussions around that being, a particular subtype now. I just wonder whether we just haven't, pulled together that data from the pollution. And again, I am not clued up enough on how like pollution levels are monitored for, other sectors that have to consider that as well as health. So it'd be really interesting. And again, this is, I think, the beauty of like population and public health, where you bring a like multi-sectoral approach, and pollution feels like an absolute significant talking point.
I think this ties in really well with the last paper that you presented, and it just sort of again emphasises that the social determinants of health have so much more of an impact on a patient's long-term health than any acute interventions that we may make as doctors. And the WHO say that it's about 30 to 55% of health outcomes are accounted for by these social determinants of health, which include where you're living and multiple other factors. But in these specific instances, living in the middle of a city versus living in the middle of a countryside, it's going to impact on your long-term health massively.
And it's just really difficult sometimes, I think, to bring up these conversations with family and just finding the time to fit it in. And also, I think a lot of us probably just don't feel like we actually have some of the core knowledge about air pollution. I was actually reading up about particulate matter the other day because I was reading a different paper. We just don't know, there's all different sizes of particles that are delineated by different terms. And the problem is you can't just measure one and observe the effect of one type, because there's all these different sized particles in the air. And like, how do you separate out exactly what's causing the problem? And a lot of people think that it's mainly like the car exhaust fumes that are causing the problem, but actually a lot of it's like the friction on the roads and like bits of the like tarmac coming up and the wheels. And then there's also indoor pollution for people who are like burning wood, because they can't afford the heating, and we don't tend to measure indoor pollution levels. We've just got like levels for like the local authority that are listed online. But yeah, it's very complicated, and I feel like we're not educated perhaps well enough on it.
Yeah, that's lots of really interesting points.
I guess one other point that I was keen to pull out from something that you mentioned, Flick, it actually quite surprises me that we don't sort of consistently record the severity. One thing that, particularly for us who are at the earlier career stage, just being really mindful of how we are like reporting our notes, so that when coders go through, things are put down as they should be. And that's just something that I think it just takes a slight shift in your mindset to put like diagnosis life-threatening asthma as opposed to diagnosis asthma attack.
Number 5.
So my education and practice article was called 15-Minute Consultation, the Prepubescent Gender Diverse Child, How to Answer Parents' Questions. Now, because it's an education and practice article, you can't just extract one or two key points in the same way as research. And I would recommend that you read these articles as a whole. But I just thought it was a really interesting article, and it's increasingly topical. And as paediatricians, we're going to be expected to know more and more about this area. As I said, I'm not going to go through every part of the article. It's definitely worth a read. They started by providing helpful definitions: childhood gender diversity, gender incongruence, and gender dysphoria. Childhood gender diversity has been defined by the World Professional Association for Transgender Health as prepubescent children who do not conform to the social norm and expression typical for their biological sex, and is a natural variation of human gender expression. Gender incongruence is defined by the ICD-11 as similar traits to gender diversity, but additionally a strong desire to be the different gender to the sex assigned at birth. And they have a strong dislike of their sexual anatomy or anticipated secondary sexual characteristics. This cannot be diagnosed before the age of 5, and it must have persisted for 2 years or more. Finally, gender dysphoria in children is a diagnosis which is defined in DMS-5. It should be noted there are different definitions for adolescents and adults because children have less insight into what they're experiencing or struggle to express their insight. For the diagnosis, at least 6 of 8 criteria must be present, which are similar to those in the definition for gender incongruence. Additionally, there must be significant distress or impaired functioning at school, home, or in social settings. In the article, they also made the interesting point on the assumption that we've long held about the brain, and that rather than there being a male or female brain, only 1% of the variation between brains can be explained by biological sex, and that a lot of what we experience as gender are the interplay between biological, psychological, and social factors. The key messages that the authors want to raise are to remember that gender diverse behaviours can be seen in 3 to 5% of prepubescent children. And from studies, roughly 16% of these children will go on to identify as transgender post-puberty. With this in mind, parents should be advised and supported to raise them with love and acceptance and age-appropriate nurture without pushing them in any direction. Their behaviour should not be pathologised. Studies have shown that familial acceptance is a key predictor for their child's longer-term mental health outcomes, although wider family and their community also play a role, obviously. This might not be easy for every family, and so the family might need longer-term support. It's definitely worth reading the parent journey that they describe in the paper.
So one thing that I found particularly useful in terms of educating myself in the current practices in gender identity was looking at the CAS review. It nicely synthesises a lot of systematic reviews that are currently available and reports on sort of history of practice and current best practices. So I think that's also another good resource for people to refer to.
Number 6.
So I'm going to talk about a review article which summarises the research on children born to subfertile couples. How are they doing? It's just an area that I realised I knew nothing about, to be honest. And I think they mentioned that now we've got approximately one child in every UK classroom who will be born using assisted reproductive technologies. And it was just a nice summary of the evidence in this area. And we're now in the sort of third generation of children who are conceived by ART. So the summary was pretty encouraging because recent evidence is suggesting that a lot of the risks that used to be prevalent are less prevalent. So perinatal mortality is much improved because we're having fewer multifetal pregnancies, and neonatal care is better. The rates of cerebral palsy are lower. This is all a result of better neonatal care. And the only issues that were still evident were that obviously preterm birth, low birth weight, congenital malformations and birth defects are still increased in this group who are born with assisted reproductive technology. However, there's no definitive association between assisted reproductive technology and risk of cancer and also risk of neurodevelopmental issues, which I think a lot of people associate with this group. And so that includes, there's no increased risk of autism spectrum disorder or ADHD. And I looked at this article really because I just wondered whether there was something I didn't know. And for this group, if I was to come across them in acute care, whether there was some conditions or something I needed to be looking out for. The risks are generally decreasing, and we're much better at perinatal and neonatal management.
Yeah, I think it's a really important article because so many couples and single people now do go through and needing fertility support. I think it's 1 in 7 heterosexual couples do need fertility support. So it's affecting lots of people. So sending love to anyone who's in that boat.
Number 7.
So this article is from the ADC Fetal and Neonatal edition and is titled Delivery Room Dextrose Gel for Preterm Hypoglycemia, a randomized placebo-controlled trial. And it examines whether buccal dextrose administered in the delivery room improves early hypoglycemia rates in the very/extremely preterm infants. And this trial, as is said in the title, is a randomized, blinded, placebo-controlled trial. It enrolled 169 neonates born at less than 32 weeks gestation across 5 neonatal units, most of which were level 3s. And the intervention was the 40% dextrose gel, or a placebo was given. And the key findings was no significant difference in hypoglycemia rates between the two groups. But there's the caveat that actually when they conducted the post hoc analysis, actually the study was never really powered to pick up a difference. So I suppose it just highlights actually we need to be cautious, because the idea of something being titled a randomized placebo-controlled trial, it's across multiple centres. They've got in 169 neonates. It sounds there's a lot of really good things in there, but actually if that initial statistical analysis wasn't done before, actually we can't really draw particular conclusions from this. And I think it's a really interesting question that the group have asked. There's a lot of neonates that come through, and it might take a little while to get that IV access. Is it the case that if we give them some buccal glucose that can improve the rates afterwards? But I think currently the advice is to continue early IV access and treatment, and then it might be that they need that for multiple reasons rather than just managing their glycemic levels. But I think it's interesting.
Yeah, it's always that rush to get the first line in, isn't it? And holding your breath whilst you get the gas result.
Absolutely.
It would definitely be nice to have a buffer for that.
Number 8.
So I've got another article from Education and Practice. As you can see, that's my thing today. This one is a 15-minute consultation on group-A streptococcal laryngitis, diagnosis and treatment in children. This is a topic that we've discussed a little bit before. I think I just wanted to bring it up again because I see so many clinicians practicing in different ways. So I thought it was worth a little refresher on it. And again, go back to the article. It's interesting. A lot of it is probably information that most of us know already. But there are a few points that I wanted to bring out of it. They start by highlighting when we should be thinking about treating and diagnosing group A strep or gas pharyngitis. So we know that in most kids with a normal immune system, that pharyngitis is a self-limiting illness. And even without antibiotic treatment, most kids are going to be better within 1 week by themselves. And antibiotics only really reduce the symptoms by about 16 to 24 hours. And I think people, including myself, forget that we used to survive without antibiotics. Not everyone, but our bodies, our immune systems are designed to kill bacteria and viruses. But our knee-jerk reaction is, we know it's a bacteria, let's start antibiotics. But as I say, it only reduces the symptoms by about 16 to 24 hours by giving them antibiotics. But what are the reasons to treat? So they pick up 4 reasons. One is literally just to shorten the duration of symptoms. So particularly if a kid is struggling with it, and maybe they're not drinking fluids very well, you're going to want to treat it. Then they also talk about reducing local subfertile complications, so quinsy and things like that, as well as disseminated disease. And then they talk about prevention of complications, which in our country we have very low rates of acute rheumatic fever, but in other countries certainly that's going to be a big consideration. And then finally, to reduce transmission of gas. So if you've got a kid going to nursery, they can spread it right the way through the group, and whilst most kids will be fine, you will get 1 or 2 who will struggle more, or they'll pass it on to their newborn siblings. So reduction of transmission is another factor for prescribing antibiotics. I took from those 4 points that there would be few circumstances where you would not end up giving antibiotics if you thought it was strep. Then they talk about the diagnosis. They talk about it looking at a few different countries' guidelines, but in the UK, we are not supposed to send a throat swab for our diagnosis of strep throat. So the turnaround time just isn't fast enough for practical management. And the only circumstances in which we should send it is if there's sufficient diagnostic uncertainty about the disease and it will impact your management, or if you're worried about resistance. Otherwise, you should be using the fever pain tool to score, which I think most people have heard of, and certainly there are calculators online. And then based on the scoring system, decide on your antibiotic treatment or not. So throat swabs should not be sent in most cases of suspected strep throat. So the other thing that they pulled out, which I thought was good to rediscuss, as I think, again, people are a bit confused, is the duration of treatment. So when I was brought up, it was 10 days. If you thought it was strep throat, it was just routinely 10 days because we wanted to eradicate carriage where possible. Actually now, in most kids, whilst 10 days is required to attempt eradication of carriage of strep, for most healthy kids, all we want to do is symptom reduction. So we can treat for a 5 to 7 day course, and that improves compliance, reduces side effects, and is perfectly adequate for most children. Those that you would consider giving the 10-day course are those where perhaps you've got other significant comorbidities. So certainly in a child with heart disease already, and in countries where there is acute rheumatic fever, you want to eradicate it where possible. But otherwise, in our country, if they've got complex medical conditions, then go for the 10 days. But for the average healthy child, 5 to 7 days is enough. Then they also talk a little bit about how to deal with recurrent strep throat and just sort of getting a more in-depth history from the family to try and pinpoint the cause of this. Is it poor adherence? Did the child spit out most of the medication? Were the parents unable to keep the timings? Just exploring adherence. And if they do think it's a problem with adherence, then you can either give an intramuscular dose of benzathine penicillin, and that's just a single dose, or you can do observed daily amoxicillin. So just 1 dose a day amoxicillin under direct observation. The other reasons for recurrence are that households also have strep, and so you might think about treating the whole family at the same time. And remembering that strep can be passed not just through respiratory droplets, but fomites as well. So it can live on surfaces. So just remembering about the environment and the family around. Otherwise, in children who have multiple recurrent strep throat, then you might consider giving, for example, rifampicin alongside, or treating with Comox or clindamycin instead of first-line treatment. And then a little note about the future of strep. They commented that hopefully rapid molecular testing will play more of a role going forward, and that there are vaccines in development. We don't have a time frame for them to be completed, but touch wood, there might be vaccinations in the future.
The point you made about throat swabs was useful, I think, because in the emergency department, what I've seen is that we do swab everything and anything where we're worried about that there might be an infection. So, ears, throat, mouth. And actually, if we're then spending time also chasing these results when that's not making any difference to the management, it's just a big waste of resources, really.
Yeah, it'll be interesting to see what changes happen as well. I think since January now, pharmacies in England can now prescribe antibiotics as well for certain common conditions. So earache, UTIs, sore throat, sinusitis, can give antibiotics for infected insect bites and impetigo. And it'll be interesting to see if that changes any of the cohorts and the children that we're seeing coming through to us.
Number 9.
So the next article I wanted to talk about is titled Nasogastric Tube Feeding Under Physical Restraint of Children and Young People with Mental Disorders, a Comprehensive Audit and Case Series Across Paediatric Wards in England. And this was published in Archives. So I thought this was really interesting because what the team was seeking to do was to better understand how common NG feeding under restraint is on acute paediatric wards in England, to find out the demographics and the characteristics of those children and young people in order to consider the additional support that might be needed. They sent out an online survey to all paediatric wards in England, and there was an additional option of people providing an anonymous case studies, and they were looking at a 1-year period. And they had a really high response rate of 95%. And that included 144 cases of young people across 55 units. So that's nearly 40% of young people who had been physically restrained for NG feeding. And the most common diagnosis was anorexia, with the duration of feeding under restraint from just 1 day to over a year. So somebody had been restrained for 425 days with a mode of 21 days. So my key learning was that actually that medical stabilisation normally for feeding takes 7 to 10 days. So the data is suggesting that NG feeding under restraint is happening beyond that point. And they discussed that for 10% of the patients, they were being NG fed under restraint without any legal framework. They also discussed that many people delivering the restraint hadn't necessarily had specific training in restraint, and that there was quite a lot of variation in practice.
So Flick, I think this very much ties in with discussions that we had during our live podcast episode recording at the RCPCH conference in 2023, particularly around the conversations about the impact on everyone in that environment.
Yeah, and interestingly, that Lee Hudson, who we spoke to, was actually an author on this paper. And I know that, I think it's Sarah Fuller, who was the lead author on this, was also at the conference at that time and was doing a workshop all about NG feeding under restraint and just trying to upskill and empower people to try to improve care for this group of young people.
And I think the exciting thing is that in that year, one of the conversations we had there was that we don't know what is happening naturally. And now we have this data, and it's incredible to see that come together. And I think that allows us to, and again, there's so much work being done in this space, and it's exciting to think about how this is, used as a tool for driving change, this data. And I was also going to say that for those who are listening, who are based in the Southwest, there is a group called the Southwest Paediatric Mental Health Network that provides a lot of resources and advice amongst the healthcare professionals, which is really worth connecting with if you are based locally. I think this is also part of a bigger piece of work being done and sort of under the umbrella of the MAP study, so the mental health admissions to paediatric wards study, which again is being run by Leila Hudson based in London. But I think it does leading to that conversation around the experience of children, young people and their relatives and carers on acute paediatric wards who are presenting with mental health presentations.
Number 10.
I think my next article ties in well with that. So it's a review, again, from Education and Practice, and it's called Recognition, Prevention and Management of Digital Harm. And this one's actually free for anyone to access. This is a topic which I think we're all quite aware of, but I think not necessarily to a sufficient extent. And we don't necessarily know where to look for additional resources. So I think we've all seen the impact of social media, increased smartphone use on children's mental health. You know, we've all seen the increase in admissions for suicide attempts, self-harm, eating disorders. And there is very little doubt that I think increasing online use is at least in part contributing to this. What I think I was less cognizant of was the physical health impact of increasing digital use. So the article sort of mentions things like long-term hearing issues. So kids who are using high volume headphones are 5 times as likely to have long-term hearing issues. Obviously, there's the link with the sleep disturbance. So that's partly through use late into the night, unless parents take the phones away at a certain time. But it's also just the blue light exposure, which disrupts their natural melatonin. And we know teenagers' sleep is not the easiest of areas at the best of times, but just throws an extra bit into the mix. Then, I mean, tying into that is the mental health, but we'll come on to that in a little bit. But poor sleep definitely contributes to poor mental health as well. And then there's the increase in obesity. So this is obviously partly due to the health inequalities, different socioeconomic groups having less access to nutritious food, and depending if they're living in a food desert. But these kids who are gaming lots are going to be sat for prolonged periods of time at an age where, 20 years ago, they would have been out running around and playing with friends outside. So as much as it was food as an impact, the lack of physical activity is also going to be contributing. And then there's the thing that I wouldn't necessarily have thought about, but again is obvious once it's raised, is a misinformation around health. So you go down a little rabbit hole, you look at something, you write something specific that you believe as a health truth into Google, and it will give you articles which are in keeping with that belief, whether or not they are true or not. Similarly, on Instagram, once you look at one thing, you get bombarded with similar things. And so you are led to believe that things are true that actually are just advertising. I think with the mental health, we are all very aware of the impact that it can have through, lower self-esteem if they're on social media platforms, the number of likes, seeing other people editing their content to make the impression of perfection. All of these things can impact on self-esteem, depression. And then when we think about self-harm and suicide, again, if you have clicked on certain links or if you go on certain forums, there's so much information out there. And it's those echo chambers where suddenly you're just getting information about this one thing. And it just creates a vicious cycle where somebody's already in a low place and then it just helps them further down that dark tunnel. Obviously, there's the bullying element. It's much easier to do cyberbullying. And this is not only from the known people, but from trolls, depending on the forums that children are allowed to access. And I think lots of parents are much more aware of controlling their kids' content. But I know a lot of kids are more computer literate than their parents. And then I think the bit that comes to us as paediatricians is the sexual risk. So the potential for grooming online from younger and younger, sexual abuse via photography. So people don't even have to be anywhere near a child to be able to sexually abuse and harm them through the content that is shared. And with the risk of online grooming is always the risk that the young person then goes on to meet that person who have been grooming them. So What can we do? I think as paediatricians, we're well acquainted with the HEADS assessment. We're not always that good at doing it completely, but this article recommends that actually we add a fourth S on. So social media becomes part of our regular questioning. And I think whilst it's not going to be practical to do for every single teenager, it should definitely be something that we're asking for the teenagers that are coming in with mental health presentations. And this article talks through red and amber flags. So the red flags that would require you to make an urgent safeguarding intervention. So receiving or sending explicit images, suspected grooming, suspected online radicalization, and online content resulting in self-harm, suicidal ideation, or eating disorders. So those would be the red flags. Then the amber flags are the more consistent but not necessarily as dramatic issues. So excessive screen time, inadequate privacy settings, viewing inappropriate content, or being unsupervised without any restrictions, or a young person presenting with poor body image. So these would be things to look into, but not necessarily an immediate safeguarding flag. So in terms of interventions, I guess that's what we all want to know. What can we do? And obviously, if we've got a safeguarding issue, then we highlight it in the standard channels. But there's also the Child Exploitation and Online Protection Command website, where you can report online abuse and sexual exploitation. And there's a Childline's Report Remove tool, and that allows you to confidentially report and remove sexual images. So those are two key things that we should remember as paediatricians and share with parents. And obviously, we're going to involve CAMS in terms of their ongoing management of their mental health issues. But there's lots of resources for both parents and paediatricians to work through. So I think part of our training now is on e-learning for health module, online safety and digital harm. But there are also some others for parents, for example, MindEd, which is parenting in a digital world, an e-learning module. There's loads of resources on the NSPCC. And there's also a website called Digital 5 a Day. So the Digital 5 a Day is how to encourage positive internet use for creativity, connectivity, and education. And it also encourages screen-free activities alongside. So we'll put some of the links to the content from that for people to recommend to parents or to use themselves. But yeah, I recommend you read the article.
Yeah, it's such an important topic, isn't it? I would encourage anyone listening to read the news article about the case of Alexander McCartney, which is it's quite a sad story, but just highlights the importance of helping children to stay safe. And then the other resource local to Bristol is Unique Voice, which I think is doing some work on online safety, and also the Safer Internet charity, the UK Safer Internet Centre, which has lots of resources and a helpline for professionals as well as young people.
And I think on the subject of mental health resources, certainly in Devon, we've got the Thrive directory. I don't know if you've all seen it. So it's a really good resource. So it just lists a whole bunch of charities and support groups that are around for various different aspects of mental health, and websites that are useful for teenagers. So if in doubt, have a look on the Thrive directory and you'll almost always find something useful.
Number 11.
I'm going to talk now about an article from the Archives of Disease in Childhood entitled Achieved Oxygen Saturations and Risk for Bronchopulmonary Dysplasia with Pulmonary Hypertension in Preterm Infants. This was a single-centre case control study carried out in the US, and they looked at oxygen saturation-related predictors of developing bronchopulmonary dysplasia with pulmonary hypertension. And then they compared this with those who had just bronchopulmonary dysplasia without hypertension as the controls. So they had 40 neonates in each, and they were all born at less than 29 weeks gestation and on respiratory support at 36 weeks post-menstrual age. The variables that they looked at were FiO2 exposure, saturation distributions, and OSI, and these were analysed in the week preceding the bronchopulmonary dysplasia with pulmonary hypertension diagnosis. And just to explain OSI, so that's oxygen saturation index, and it looks at the relationship between oxygen administration and oxygen exchange. And the equation is MAP times FiO2 times 100 divided by SpO2, just to give you an idea of what it involves. And so when they looked at the data, infants who had pulmonary hypertension on top of the BPD achieved lower saturation distributions compared with those with BPD alone. And they were also exposed to a higher FiO2 in that period before diagnosis. And in terms of the OSI, the infants who had BPD with pulmonary hypertension had a higher OSI in the week preceding, again, their echocardiographic diagnosis. So this OSI was good at differentiating infants with BPD and pulmonary hypertension to those who just had bronchopulmonary dysplasia, with a high sensitivity but a low specificity. And there was progressive discrimination of the OSI after 36 weeks post-menstrual age, which I thought was interesting. So the difference became more marked. And in addition to comparing those variables, they also looked at those who did have pulmonary hypertension who survived as opposed to non-survivors. And non-survivors achieved a lower saturation distribution compared to those who survived. But OSI itself was not predictive of survival. So to summarise, FiO2 and saturation distributions did differ significantly between the two groups, and OSI was predictive as well. But the OSI didn't differ significantly between survivors and non-survivors. But overall, they concluded that this was really useful because it's difficult to predict. I think it's something I've certainly seen, which infants will develop pulmonary hypertension. And if these can be used as markers, then further studies can be done and we can see whether interventions can modify the OSI and the outcomes for these infants. Bronchopulmonary dysplasia is impacting 50% of extreme preterms, and 40% of those will also have pulmonary hypertension. So it's a big issue. So hopefully these predictors, particularly the OSI, can be used to generate further research and potential treatments for these infants.
And number 12.
So the next article that I'm going to talk about is from ADC Education and Practice, and it is a 15-minute consultation entitled Empowering Children, Young People and Families Through Shared Decision-Making, a Practical Guide. So this starts with a definition of what shared decision-making is, which is a collaborative process where healthcare decisions are informed by the best available evidence and aligned with patient preferences, values, and goals. The article offers some practical steps for implementing shared decision-making, starting with, firstly, ensuring children, young people, families have reliable access to information from reputable resources in the ways in which are most accessible to them, and encouraging families to ask 3 key questions to ensure that their decisions are informed. The first one is, what are my choices? The second is, what is good and bad about each choice? And then the third is, how do I get support to make the right decision? They then go on to suggest co-producing resources with families, and that's a way in which we can ensure children, young people and their caregivers feel that healthcare is moved from a place where healthcare is done to individuals to being done with, and creates empowerment. And that can be resources to inform what can be expected from a particular outcome. It could be what can be expected from a particular procedure. It doesn't matter what it is, but it's the idea that actually if you have resources that are not only accessible but are created by the young people that are using them, then there is added value in the way in which that information is going to be processed and used to inform individual decisions. Thirdly, when it comes to thinking about how these decisions are documented, ensuring that the reasons behind why decisions were made are included, the discussions that were had around those as well, and then details about the follow-up plans are communicated back to the patient, so written in letters shared with other practitioners who might be involved in that child's care, just so that not only, for that child as they kind of grow up, they might have the opportunity to look back and say, why were these decisions made, and was I involved in them, and what was that? But actually, I think it provides that continuity and opportunity to perhaps reevaluate, because decisions may change if that's appropriate for them to do so. And then finally, there's a section about measuring the effectiveness of shared decision making, and they list a number of validated tools. One that particularly stood out to me was the shared decision making Q9+1 tool, and this lists a set of variables and questions that can be asked to again check in and see how this process is being implemented. And yeah, I think this article is particularly pertinent. I really relate to it, and I think it's something that we would all like to think we strive to ensure that the decisions are being made. And again, there's a huge variation depending on the acuity of the scenario, but I think any opportunity to think about how that young person's voice is influencing the way in which we deliver their care or communicate with them, whatever it may be, is really useful. And to have, practical steps to evaluate that process, I think it's all really useful article, and I suggest people read it.
I think it's really important that we try to include young people's voices. I went to a meeting recently, and it was really interesting as a bit of an MDT, because I'm so used to starting off from the perspective of professionals presenting their opinions and then coming to the family at the end or checking in with them. And instead it actually started with the family. So rather than having the professionals meet first, actually the parents met with the chair first, and they started off the meeting by family presenting what they felt was going well, what they felt needed to be improved. And it also ended in exactly the same way in terms of the summary. And I thought it was really interesting to actually start and end with the parents and the young people and their voices rather than the professionals' voices. And it just seemed to completely change the setup and nature of the meeting somehow.
Love that. And I think there's a whole conversation to be had around engagement, and it's something that I think my experience really comes from the world of research, and it's a conversation that I'm hearing a lot, in all the different meetings I'm going to, about how we involve children, young people, family, relatives, patients, whoever it is that is the sort of beneficiary of the work that we're doing in the conversation from the start. And that's what this term co-production somewhat means. And it's something, we like to say it's a sexy term to be used, the idea of co-production, because you like to think that you include it in all of your services, but actually there's sort of not as many examples as you like to amplify what the true value of being able to ensure that in an accessible way in which you're again going out to people who are underserved by our current systems and getting their voices, and then really using that as a way to prioritize what aspects of the care or the service or the decision that's being made is important to that individual at that time, and then working with them throughout that process to we come as healthcare professionals with the evidence and an understanding of that and our routine practices, but we are not an expert in the individual in their care. So I think finding ways to marry up those partnerships is something that I'm particularly striving to do so.
So we'll tie up this episode, as we try to tie up all of our episodes, with recommendations. So does anyone have any book, film, podcast recommendation from the year?
Well, from the year is a bit tricky because I tend to read older things. One of my absolute favourite books is Midnight's Children by Salman Rushdie, and it seemed appropriate because it involves a load of children as the characters, and it's just magical realism, and it's beautiful, and there's also a lot of history interwoven because it's at the end of the British colonial rule in India, and it's just incredibly descriptive and beautiful.
Yeah, he's been on my list of authors to read. So he was interviewed by Elizabeth Day, because she does my favourite podcast, How to Fail. And he came and did a really incredible interview with her. So I'll have to read it.
Oh, his books are just, phenomenal.
I can't say that I read very much anymore, but I audio listened to The Salt Path by Raynor Wynne. It's a story about a couple who became homeless and decided to start walking the southwest coastal path from beginning to end. And it's an amazing story about their journey, and really descriptive, shows their ups and downs, but it also has lots of facts about homelessness in the UK, which I had absolutely no idea about. So I recommend that from multiple perspectives, but it's really left me wanting to walk the coastal path as well.
I love walking on a coastal path.
Me too. I've actually had lots of disastrous experiences on that coast path, but through my own fault of walking in the wind and rain and storms in November along large sections of the path, because it's fun.
I was just going to say that I'm actually really looking forward to the new series of Squid Games that's coming out this Christmas. Did you guys watch last year or the last series?
No, I haven't.
Oh, I'd recommend it.
So my recommendation is also something slightly different. And I recently heard about this comic. So I don't think I've ever really read comics, but it's been put together as the result of some research around obesity and weight loss and interventions there. And it's called The Weight of Expectations. And it is part of a group called Act With Love. And that's how you can find it online. And it's exploring obesity stigma. And it basically just communicates some findings from a key research paper, but in a way that's accessible to the wider public. And I particularly like this because I think it kind of perhaps ties up some of the conversations that we've had today, in that actually some of this knowledge feels that it's quite hard to access. And, we've gone, a part of our routine practice is to read papers and, distill those down into information, but actually thinking about other tools that we can use to communicate these findings and get them more widely out there. And I just love the idea of using a comic as a way to do so, just like a few pictures. And I know that the creators of this have also then taken some of that artwork and put that into larger displays and exhibitions, and use that as a way to communicate and get people talking about this topic. And I wonder if, there's some lessons to be learned there as well for how we communicate.
You just made me really, really want to read that. So you've done a good job of advertising it.
I waffled a bit, but it's pretty cool.
Can I make one film recommendation?
Mm-hmm.
Yeah, please make a film recommendation.
I don't know if I've already recommended this once, but The Green Book. So it's a film that came out a few years ago, and it's based in 1960s America, and it's a black classical pianist who does a tour of the Deep South with an Italian driver who's sort of his bodyguard. And I cannot recommend it enough. It's watch it. I don't want to go into too many details, but I've watched it a few times in a row and really like it. So go for it.
The other thing I was going to say that I finally got around to doing this year was reading Lessons in Chemistry by Bonnie Garmer. So we've had two people who've come on the podcast now and have recommended this book, and I finally got around to reading it. And I can also say I quite enjoyed it, so I would recommend it too. Thank you so much for listening to this episode. I hope everyone's enjoyed it and had a great 2024.